medical treatment is always immediately you should start in the first 24 to 48 hours. So normally we go for quinolone derivatives, and also non-steroidal anti-inflammatory drugs are also used in the initial period. Then subsequently we stop that. So initially this case was presented like this with the corneal edema. After medical therapy, you can see immediately the peripheral spasm is reduced and the ulcer is contained and opacity is reduced, iris strictures are visible, fundus is also visible. But in this dog here in the Shih Tzu, you can see a corneal ulcer, very severe corneal ulcer, and this corneal ulcer was actually descemental seal was also broken, and because of that there was also escape of the anterior chamber. But with all that, medical therapy was attempted, and it's such a good cooperative patient, and you can get finally you got a very good improvement. So after getting such a good epithelialization, now you do again fluorescein test, and if you feel that your epithelialization is complete, but at the same time you have to work on the pannus, the neovascularization is there, then you can think of using topical soft corticosteroids like loteprednol initially, and recheck the animal after 2 days, and then continue if there is no further ulceration. Sometimes use of these drugs can also, because it is highly contraindicated on a topical, but if the epithelialization is complete and if vascularization is there, I normally go for soft corticosteroids and then treat the conditions. You will get the transparency back. So this is a corneal ulcer, grade 2, which is a healed ulcer after healing, shown from different angles. So after once the ulcer heals, two things I have seen. One, either it will develop an opacity or it will develop a pigmentation in that area. This is again a corneal grade 2 ulcer after healing. So pigmentation is again a sequelae here. This is the grade 4 ulcer with the keratoconus. So you are almost, the cornea itself is lost. So these things definitely require, you don't have any healthy cornea also to anchor any conjunctival flap. So in such cases, you definitely need either a third eyelid flap, but now we are going ahead with the amniotic membrane. You get good results. Complicated, this is a complicated corneal ulcer after healing in a pug. You can see the corneal pigmentation on the medial canthus. So the Google, so this crescent blade is very important, and so with the help of the crescent blade, you will be able to dissect the cornea, and then you will be able to dissect the cornea, and you will be able to also remove some devitalized tissue from the cornea. So that is also very important. So the take-home message is, actually the dogs and cats cornea have considerable capacity for repair and the re-establishment of the transparency, and take care of the intactness of the precorneal tear film. That is also very important. Now comes the keratoconjunctivitis sicca. This is a stimulation of the tear production by use of cyclosporin, is the one which commonly I have seen whenever the case is referred. But the cyclosporin never works on an infected eye. So that you should always remember. And it can modulate tear production. It is a lacryomimetic drug, but it can modulate tear production, but not in an infected eye. So always try to clear the infection first and then work on the use of cyclosporin. So chronic conjunctivitis, so you will find lower tear production. So these are all, eyes will become sticky. Another important thing is when you try to do a STT test on this eye, so it is very easy because the paper will stick to the eye. Okay, so these are the things you should check when you do a for a KCS. And after clearing the eye, our first aim is to reduce the infection. So that, and at the same time, lubrication also should be there initially to reduce the infection. So you can always go for some ointment-based, plain ointment-based antibiotic ointment with antibiotics. So with initially maybe 1 or 2 days we can use eye drops also, but in the night time I will always make them to use some ointments. So in that case it will lubricate, and you can ABS result will also give a result in 2 days time, and you will be able to control the infection. So after controlling the infection for 7 to 10 days and to take care of the precorneal tear film, then you can work on cyclosporin. So the cyclosporin now will get attached onto the cornea, onto the precorneal tear film, and you will get a modulation effect. Lacrimomimetic effect will be there, and also pigmentation also will be reduced. My experience is when you use tacrolimus, the pigmentation is more reduced than the cyclosporin, but there are cases where cyclosporin only responds, not the tacrolimus. So use of artificial tear preparation is also very important, and lubrication ointments are also very important. Surgical management mainly aims at taking care of the tear film, whatever that has been formed. So that is why in case of brachycephalic breeds, you can just close the lateral eyelid alone, that is called lateral tarsorrhaphy can be done. This is mainly to shorten the palpebral fissure so that the evaporation of the tear film can be controlled, and also the tear lake will be small. So whatever tear film that is present will take care of the lubrication. So some dogs will also develop corneal ulcers. So there you need definitely a flap for attending to such conditions and then treat the cases. The permanent treatment in the textbook, like parotid salivary transposition is a highly demanding surgery, and which we have done in few cases, but results are very poor because frequently you have to feed the dog to stimulate the salivary secretion, and accordingly the tear secretion will be the lubrication of the tear ocular surface will be improved. But now we have advanced medicines, so with the help of that, cyclosporin implants are also available. You don't have to frequently put the drops, and you will be able to treat these conditions with the medical treatment. Eyelid tumors are also another worry, which actually affects the eyelid. Even if it is a small tumor, when you hear that it is a small tumor mass, so they will ask you to immediately remove. So such patients, you have to go for a eyelid removal on the affected part alone. So a V-shaped incision can be put, and the excision of the eyelid can be done, and the neoplasms can be removed. So the chalazion forceps and all those forceps which I said in the IPAC are very important to treat such conditions. You also need a small microsurgery blade. But when you close the eyelid, you have to definitely use a two-layered closure. That is very important. So inside first you have to close with absorbable sutures, and on the outside you can close with mainly the non-absorbable sutures. So the skin and the orbicularis oculi muscles are actually opposed with the simple interrupted sutures and the interrupted non-absorbable sutures. So the taking a bite on the orbicularis oculi muscle is also very important in such cases. Corneal lacerations. Sorry, purposefully I did not put any picture. Please listen to what actually I say, because the cornea is a four-layered or a five-layered structure. Debate is still there whether histologically there is a basement membrane or there is no basement membrane in the canine cornea. But lacerations subsequent to that, prolapse of the iris tissue is a very common thing which you would have seen in your practice. If it is a healthy tissue, that can be repositioned into the anterior chamber. You don't have to worry about that. Iris tissue can be repositioned. And if it is outside for a very prolonged period of time, maybe more than 8 hours, then definitely it requires a removal. So that prolapsed part alone can be removed with the help of a iris scissor. So mild traction can be applied and then removed. And also you can cauterize the uveal tissue. The cautery which you should use again should be a ophthalmic cautery, not the soft tissue cautery instruments. And care also should be taken to not to cauterize the cornea. So that is why we normally place some fringes of cotton around and apply the cautery on the iris alone. And anterior chamber can be always filled from the side port with the Ringer's or a BSS solution. And if you try, sometimes to arrest the hemorrhage, we use viscoelastic agents. If you use viscoelastic agents, it has to be removed after the final placement of the suture on the cornea. So selection of the suture material, again we said about 7O to 10O can be used. Again, an absorbable or non-absorbable can be used. So when you actually, this is a proper placement of the suture material, and this is too shallow placement of the suture material. It has not gone up to the complete depth, but at the same time it should not pierce also. Okay. So this is the tension of the suture line. In this diagrammatic representation, we have seen the tension at the suture line. You can see here. So simple interrupted sutures can be taken, and if you apply excess tension, what happens? There will be gapping at the wound edges. So the placement of the suture should be sufficiently deep, but at the same time, you should not traverse through the endothelial layer. That is very important. The epithelium, the stroma, up to the stroma, deeper stroma, it can cut and take a bite and then come out. So the endothelial layer you are not supposed to touch when you do it, because it can cause some endothelial damage, endothelial edema, etc. So proptosis sometimes can be a very small proptosis like this. This is a partial proptosis where there is a tear on the straight muscles on the medial rectus as well as on the oblique muscles. So you can see a mild rotation of the eyeball up. So this can happen mainly in the small breeds of dogs, mainly due to trauma and head trauma and also pressure. And in brachycephalic breeds, it is very common. In cats, proptosis is not a very common condition. It is an uncommon condition. And you need, actually, they say more pressure or the force required to affect proptosis in a cat eye is more. That is why injury will be invariably followed by fractures of the facial bones. So this is the typical proptosis you see in case of animals. So what happens is when the eyeballs are proptosed, there will be entrapment of the eyelids behind. So you will not see the eyelid margin at all. And when you view from the side, you can also see the more than the equator of the eyeball is outside the orbit, and there is decussation of the cornea. And try to visualize after lubrication of the area, try to visualize the status of the pupil. If the pupil is myotic, then there is some prognosis in improvement in vision is there. So if it is replaced immediately, they say 40% chances are there. And myotic people normally, when we reposition, we get a good improvement. So the prognosis for a replaced eye is actually depends upon the trauma to the adjacent structures as well as to the cornea. So also check for PLR and also cross reflex, and presence of the ruptured medial rectus is one thing which you have to attend to. So sometimes if it is a very severe rupture is there, we need to reconstruct the medial canthus or medial rectus also subsequent to the suture reposition. Now another common condition which you get in the eye is, apart from cataract and glaucoma, is we'll go back to the last portion, that is the retina. Those cases like this are present, you will find hemorrhage inside the eye, hemorrhagic deposits inside the eye like this, or sometimes complete hemorrhage, or the retina displaced anteriorly like this. You can see a portion of the retina instead of the lens. So such types of ocular manifestations are common due to cardiovascular and blood diseases, especially anemia, hypertension, or it can also result in hyperviscosity syndrome. You can also check for the thyroid as well as the cholesterol level, and then you will find. So you have to correct the condition. This happens mainly in bilateral eyes, with both the eyes. Hence, the main ocular changes associated with this are the tortuous retinal vessels, and sometimes you will find retinal hemorrhage. If you can see the optic disc, there will be papilledema, and reflective changes, the retinal reflective changes will be less, and followed by the detached retina like this. So in such cases, the hypertension induced by renal diseases are very common, which we have seen in dogs. And so you have to necessarily do a vital organ test and try to attend to the major part, and then you can also attend to the eye, mainly by giving some neurotropic agents as well as by giving some antifibrinogen agents. Either if you can see that the settled fibrins are there, you can also do a lavage and then remove the fibrin from the eye. You can also inject, so in some cases we also inject intraocularly antibiotics into the eye. So the secondary glaucoma effect also you should rule out in such cases whenever there is a chamber, anterior chamber hemorrhage inside the eye. So this is because we have studied about the drainage of the aqueous humor. It happens mainly through the 80% through the trabecular meshwork and some 20% through the uveoscleral outflow. So the trabecular areas will be blocked and it will result in a closed angle glaucoma. That is why how you get secondary glaucomas in such cases. Anemia and hyperviscosity syndrome, hypercholesterol, you will find deposits like this inside the eye. You will also find pale vasculature, which will result in blindness. So viscosity, if the serum viscosity they say is 4 to 5 times the normal, then only the ocular signs will be manifested. After all, the aqueous humor is an ultrafiltrate of the blood plasma. So you will find all these changes when the viscosity is more. Also, intravenous fluid overload also is another cause which we have seen in our practice here. So the cases will be referred to us, and we will find because the patient will be brought for a dehydration status and fluid intake. The fluid therapy overload will be there, and that can also result in pale retinal vasculature as well as retinal toxicity and hemorrhage, papilledema, and bullous retinal detachment. Thrombocytopenia is also another cause which can also arise due to any systemic infection, and the main therapy should be directed to the underlying cause like blood transfusion or even platelet-rich plasma also can be transferred if indicated, and then you can look into the problems into the eyes. So this is mainly the anterior chamber and the retina. So we have seen in systemic infections, the anterior chamber and the retina will be affected, and you will also find changes in the optic disc. So the main concern whether the vision will come back or not always depends upon how early you treat such patients and how early the treatments are directed towards the underlying cause. So ocular manifestations of some systemic diseases like canine distemper, specific diseases like canine distemper, leptospirosis, ehrlichiosis, diabetes mellitus, and toxoplasmosis. So these are also very common in dogs, and toxoplasma is very common in case of cats. So typical anterior uveitis will be there. Initially there will be pain and diminished vision will be there, and aqueous flare. We have seen what is an aqueous flare. So to identify small changes like this in the anterior chamber, your slit lamp examination will help, and you will be able to treat the conditions accordingly. So whenever there is a more aqueous flare, your immediate worry should be to prevent any synechia formation. So treatment should be aimed at that, and then try to reduce the viscosity and then correct the condition. So antibiotics, of course, will play a very major role, and with the administration of some ocular inflammations, you will be able to treat only with the corticosteroids. So that also you can think of if it is possible to do, especially in canine distemper and all, corticosteroids are not indicated. So the nerve fibers, of course, there is absence of these nociceptors in the choroid and in the retina. So that is why in posterior uveitis, we will not find much pain. And also in the optic nerve, during proptosis also, I forgot to mention, in the optic nerve also there is no nociceptors. That is why a proptosed eye, though it will look as if it is a very painful lesion, there will not be much pain from the animal side, and pain will not be experienced by the animal. But in case of anterior uveitis, if the ciliary body is affected, if the iris is affected, then definitely there will be much pain. So you have to definitely include analgesics also in the prescription. These are the secondary lesions you find in the eye, basically due to systemic infections. So do a thorough good exam, physical exam. I want to stress that point. Physical exam is very important. Herpes infections in cats you will find conjunctivitis and iridocyclitis and sometimes deposits inside the eye or hemorrhage inside the eye. So you can treat it with a proper antiviral agents. You have acyclovir antibiotic and acyclovir ointments as well as drops are available. So you can depend upon that, and also try to improve the immune status of the patient, and also try to take care of the ocular status and the posterior part. So all these things should be there in your mind when you treat such infections in the cats. And endophthalmitis due to or panophthalmitis in cats, normally they develop subsequent to enlargement of the globe and secondary glaucoma. So all these are indicative of sarcomas. Ocular sarcomas are very common in cats when compared to dogs. So in case of dogs which are brought with some mild proptosis, this is no proptosis, but you can see more of the sclera, but the pressure is very normal in the eye. So in such cases, you will find some injected blood vessels like this. So these are all indications that there is some tissue, there is some mass that is pressing the eyeball and it is affecting the proptosis. So definitely you need some additional X-rays or a CT scan to rule out. In such cases, anything you doubt on the posterior aspect, try to open the mouth and then look for the presence of any foreign bodies or intactness or the hygiene of the tooth, oral cavity. So all these can be attended to. So the next important visual threat which you get vision affection is the cataract. So cataract can be either different types of opacities of intensities of cataracts are there, and you can also grade the cataract accordingly. This is a immature cataract, and this is a stellate cataract where the sutures are matured but the cortex and other materials are not matured. But this is a long-standing process. Long-standing cataracts only you will find such problems. So the patient preparation as well as this is very important in such cases. You were talking about the dorsal recumbency of the patient. So definitely the animal should be completely monitored, and there should be a separate faculty for taking care of this part. And this is the guarded ET tube which you have to use in case when you want to flex the head and then position the head like this. So this is how the head is positioned, and in the few pictures I have shown, the head is positioned so that the tapetal reflection will be just underneath the oculus of the operating microscope. So ECC, that is the cataract, mainly done for removal of the cataractous lens. So that is actually not a refined method of cataract, but if the cataract still it is in vogue, because though sometimes with the phacoemulsification, if you need more energy, then you have to depend upon the removal of the complete rock-like cataractous lens from the eye. So the eyeball can be approached from the cornea, and then you can make a corneal incision, and after the corneal incision, putting a larger corneal incision, the lens is removed. So in the ECC, that is extracapsular cataract extraction, the capsule is actually maintained. The PC is also maintained. You are not removing that. But in case of intracapsular cataract extraction, that is ICC, this normally we do only in case of cataracts, cataracted lens which is luxated into the anterior chamber. So in such cases, you have to necessarily remove the cataractous lens along with the capsule. So the anterior capsule and the posterior capsule along will be removed. So in doing so, again a larger incision is made on the cornea with the help of a corneal scissor, and the cataractous lens can be removed, and the cornea can be sutured with the help of a corneal 8O or a 10O sutures. So, but actually what happens here is, in the ECC, you are not touching the vitreous, whereas in the case of intracapsular cataract extraction for lens displacement, the vitreous also will be in touch with the capsule. So while removing the lens along with the capsule, the cornea also will be will be smeared by the vitreous that is present behind. So that can actually cause some opacity subsequently. So that is one thing you should remember always when you do an ECC, ICC apart from ECC. So the preferred method for any cataract, if at all, if it is brought in the early stage with the help of a phaco fragmentation, with ultrasonic waves, you can emulsify the lens, and the whole lens material can be removed with the help of a phaco machine. So here, through a small incision, you will be able to do, and sometimes we don't put suture, or sometimes we also put sutures inside the eye. So the next step is, after the phaco emulsification, you can also refine it by putting the intraocular lens in its place. This is that putting of the intraocular lens, and this is how the intraocular lens has to be loaded from the from its strip, from its package. So this picture shows the presence of the intraocular lens inside the capsule. So when we talk about phaco emulsification and IOL surgery, the intactness of the capsule is very important. So always you can keep the intraocular lens, and if the capsule is weak and you feel that the PC is weak, then it is better not to put the intraocular lens. You can leave the eye as aphakic. And so this is how you load the cartridge, and then you can put the cartridge is loaded, and then the lens come out through that cartridge, and then you can inject it into the eye. So these two pictures actually shows the position of the eyeball. So earlier we were putting this is mainly to show you the presence of the sutures around the eye. So you can also, if you have a good anesthetic regimen, then you don't have to put any sutures with your normal, because now we also give subtenance block. So you will be able to get a good proptosis of the eyeball, as well as with the help of a blepharosphere, you will be able to get a good positioning of the eyeball, and then followed by that the IOL is implanted. Cataracts are more common in case of cats also. So these are all immediate follow-up. You can see the air bubble still inside the eye. These are all aphakic eyes where the lens has not been implanted following cataract surgery. This is again an aphakic eye. Invariably what happens, the big advantage of cats, I have done phaco emulsification in lion also. So they all belong to the same family. You will not find any reaction in the cornea, like as you get in case of dogs. So it will be a very, as in case of human beings also, you don't get reaction. We are lucky in that way. So this picture shows the presence of a intraocular lens in the eye of a cat. Normally we don't put, because the availability of the lens is not that easy. Intraocular lens power that is required for a cat is plus 51 diopters. We need a very high power lens, and this is called a pseudophakic eye, because an intraocular lens is pseudophakic refers to lens. So aphakia, lens is not there. Pseudophakia, and intraocular lens is there. So this small kitten is now waiting for surgery. It's a very small kitten with a cataract. So this is all nutritional deficiencies. That is why you find cataracts like this in the very early stage. Luxations of the lens is also common. Instability occurs mainly due to weak zonules, and the weak zonules are again due to even thrombocytopenia can also cause a weak zonule. So secondary glaucoma also can cause a weak zonule, and the lens will get luxated. So this is all this. Here you can see the lens in the anterior chamber. In this picture you can see it behind the iris. That means it is still in the posterior chamber. So surgical removal either by phaco emulsification or intracapsular cataract extraction can be employed. Cryo extraction works well with the intraocular, with the lens removal in case of luxation cases. Glaucoma is another major area of eye where vision threaten is a very major problem, where you will find the partially proptosed eyeball, and you will find also opacities. So this is a opacity which you see, but it is it is controlled. Your IOP is controlled, but still you have opacity. So this type of opacities you mainly see is basically because of the Descemet's tear in the glaucoma cases. Whenever the IOP is raised, there will be tear of the Descemet's. That is actually called Habs trias sign in glaucoma. And in addition to that, you will also find sometimes vascularization and opacity, etc. So definitely, I will show you one case where, so this was an immediate case with the glaucoma. So after giving the proper treatment of glaucoma with anti-glaucomatous drugs and also painkillers, after 4 days, you can see an improvement, immediate improvement like this. So the effect of pressure can either actually deviated towards the anterior chamber, then you will find all these problems. Or the effect of pressure can be more towards the optic side also, posterior segment. Then the optic nerve will be affected and you will find atrophy of the optic nerves and vision will be affected. So if the pressure is more on the anterior chamber, there is chances for the vision to regain in glaucoma cases. But if it is more on the posterior segment, it is definitely a neuropathy and improvement in vision we will not be able to expect. So prognosis is poor. So glaucoma, when you are not able to treat with the medical problem, medical drugs, then you can treat it surgically. So the drainage angle can be improved mainly through trabeculectomy. So you can approach through the sclera and then you can remove a small piece of the iris and the sclera can be sutured back, and you can also, to improve the filtration life of the filtration angle, you can also put some mitomycin there and then suture the area. So mitomycin, whenever you use, you also should be careful when handling, as well as after application of the mitomycin, also wash out the area because they are all antimetabolites. In place of this, we also use gonio implants. So you can see the gonio implant. This is the Surgiware gonio implant. This is a valved gonio implant. So what happens is when you put this subsclerally, you can see the tail portion of this projecting into the anterior chamber. So whenever the pressure increases, it gets drained through the subscleral spaces, through the valve into the subscleral spaces. So that is another, apart from the trabecular and the uveoscleral, we are creating another drainage, that is with the help of gonio implants. So that is these are the very common problems normally you find in dogs, and any deeper like a posterior segment where retinal detachment, whether it can be treated surgically. So all these are we are yet to start, and you can also scan this QR code to watch a demo on how to use eye drops in dogs. So I have that is there on the YouTube, and also, or you can also scan this QR code. So with this, I think we have come to the end of the presentation, and so I thank the platform actually given to me, and also opportunity rather given to me by the Managing Director Dr. Vishal from Oriheal Life, and also from IVA for giving excellent opportunity to me, and as well as I hope this webinar would have improved knowledge to some extent for the participants, because it is an online. I hope it would. That is why we started with the module 1, module 2, and then slowly we came to the module 3. Thank you very much.